Good morning, everyone. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about occiput posterior fetal position. So what we wanted to discuss today? The definition, epidemiology, etiology, how to diagnose, mechanism of labor, management, and lastly the complication. Okay, look to this picture, please. Occiput posterior position means a longitudinal lie with vertex presentation in which the fetal back is directed posteriorly. This is the sacrum and this is the fetal back directed posteriorly. Also, it is fetal position with the occiput towards the maternal sacrum and the face toward the maternal symphysis pubis. Occiput posterior is the most common fetal male position. Okay, what about the epidemiology? The occiput posterior position during the first stage of labor occurs in 10 to 34% of cephalic presentations. Most of them, 90% nearly, will spontaneously rotate to anterior position and delivered as occipito-anterior. But the remaining 10% will be persistent to occipito-posterior, as we will see in the lecture. Why it is important? Because it is associated with labor abnormalities that may lead to adverse maternal and neonatal morbidities. Also, operative vaginal delivery or cesarean section. Okay, occipito-posterior may be primary or secondary. Primary means it occurs during pregnancy and before onset of labor, and this commonly seen with anthropoid pelvis because the head rotates posterior in the sacral concavity. While the secondary developed during labor due to posterior rotation from the lateral position and occurs more commonly with android pelvis. What is the etiology of occiput posterior position? The abnormal shape of the pelvis constitutes the majority, 85%, and the commonest abnormal shaped pelvis is the android pelvis associated with occiput posterior. Other types like anthropoid and the gynecoid with narrow forepelvis. What are the other causes which constitute 15%? Laxity and anterior abdominal wall of the mother as in pendulous abdomen, minor degree of maternal kyphosis, uterine fibroid, ovarian tumors, multiple pregnancy, hydramnios, and the anterior insertion of the placenta. Or the etiology is sometimes unknown, so idiopathic causes also present. Less favorable fetal head diameter in occipito-posterior associated with deflection of the fetal head and posterior presentation. Usually correct spontaneously in 90% of cases, rotates to occipito-anterior and delivered normally. How to diagnose a case of occiput posterior position? During pregnancy and during labor. During pregnancy, by inspection to the abdomen, please look to this picture. This is occipito-anterior and this is occipito-posterior. Can you see the difference in inspection of the abdomen? The abdomen locks flat in occipito-posterior position with subumbilical groove. As you see here, this is a subumbilical groove between the head and the neck. This groove between correspond to the fetal neck. Okay? Fetal movement also may be detected on each side near the middle line or on both sides. By palpation, while we are doing obstetric grapes, fundal grape will feel the buttock with its soft, irregular, non-palatable, not tender criteria. Umbilical grape, the back of the fetus, felt away from the midline, and the anterior shoulder is felt away also from midline, more than 3 inch. Limbs are felt on one side near the midline or on both sides. By using first pelvic grip, head is felt smaller and tend to recede from the palpating finger as we feel the smaller bitemporal diameter instead of biparietal diameter in cases with occipital anterior. Head is usually not engaged due to deflection of the fetal head, which is diagnosed by second pelvic grip. So second pelvic grip will help me in diagnosis of deflection with some degrees of deflection, mild, moderate, and major deflection. In the moderate deflection, the occiput and the sinciput will be felt at the same level. Infrequently, the head is engaged. We may need combined grip, especially to differentiate between the head and the frank breech, because occipitoposterior position in differential diagnosis of frank breech. So when I hold the upper pool and the lower pool, I can differentiate. By auscultation, where the commonest site for the fetal heart sound can be detected? In the flanks, locked to this region, on both sides, according it is right occipitoposterior or left occipitoposterior in the flanks, because the back is away from the middle line. Okay? Ultrasound confirms the diagnosis. As you see in the picture, this is the fetal spine and this is the occiput here. So it can be easily confirming the diagnosis of occiput posterior position. During labor, early in labor, the membrane is not ruptured, felt as sausage-shaped projection, and if membrane ruptured, you can feel the fontanelle, the anterior fontanelle directed anterior and the posterior fontanelle directed posterior. Also, the anterior fontanelle directed toward the obturator foramen, while the posterior fontanelle directed toward the sacroiliac joint, while the sagittal suture lies in the oblique diameter. What are the degree of flexion you can diagnose? Mild or moderate or major deflection. In mild deflection, both anterior and the posterior fontanelle are felt, but the posterior fontanelle is lower than the anterior. While in moderate deflection, both anterior and the posterior fontanelle at the same level. While in major deflection, the anterior fontanelle is at lower level than the posterior fontanelle. Also, you can feel sutures and the fontanelle, but sometimes it is masked. Why it is masked? Because of caput succedaneum. So, how can I know the anterior from posterior if the sutures and the fontanelle are masked by the caput succedaneum in the skull? Through the ear, through the tragus of the ear, the direction locked to this ear, the direction of tragus of the ear towards the occiput. And you can palpate easily the posterior ear because it is more space for examining a finger. So the direction of the tragus of the ear denoting the occiput. Okay? What is the mechanism of labor in occiput posterior position? A certain degree of deflection is present in all cases of occipitoposterior. Why? Two factors, really. Look to this picture. The opposition of the convexity of the mother with that of the fetus is reflected on the body of the fetus and also the head. So the head will be deflexed. So both convexity meet each other. So the head becomes deflexed. The other factor is that the wide parietal diameter, which is 9.5 centimeter, enter the pelvis in the narrow sacrocotyleate diameter, which is 9 centimeter only. That's why there is delayment in the descent of the occiput in cases with occipitoposterior. While the small bitemporal diameter, which is 8 centimeter, occupies a wider oblique diameter, which is 12 centimeter, which favor descent of the sensibut. So the sensibut descent earlier than the occiput because the sensibut descent in a wider diameter. Okay, so descent earlier than the biparietal diameter. That's why there is deflection. So these two factors are the cause of deflection occipitoposterior. The effect of this deflection brings larger occipitofrontal diameter, which is 11.5 centimeter, instead of suboccipitopragmatic diameter 9.5 centimeter, thus increasing engaging circumference of the head, which leads to delay in engagement. So I have delay in descent and delay in engagement and deflexed head. According to the type of pelvis, the degree of deflection and the efficiency of uterine contraction, the outcome of occipitoposterior will be two groups. Normal mechanism in 90% with long anterior rotation 3/8 circle and delivered as occipito-anterior, or abnormal mechanism which is a persistent occipitoposterior in 10%. As in this picture, this is the normal mechanism constitutes 90% and this is the abnormal mechanism constitutes 10%. Please look to this picture about the mechanism of labor to understand that very well. The mechanism of labor include normal mechanism in 90% where the occiput rotates 3/8 circle anteriorly and delivered as occipito-anterior, and this occurs spontaneously during the second stage and the first stage of labor. Okay? While the abnormal mechanism includes three groups. Either the first group, there is incomplete forward rotation. I mean, the occiput will rotate 1/8 circle anteriorly. That's why the position of the head will be transverse. And we call it deep transverse arrest. So this head rotate 8 circle anterior, so becomes deep transverse arrest. While the second group, there is no rotation, so there will be persistent oblique occipitoposterior, as in this picture. Nothing changed. As you see here, the same as here. So there is no rotation. Actually, this happens when the sensibut and the occiput at the same level, as in cases with moderate degree deflection. So there is no rotation. We know that the first part of the head which reaches the pelvic floor will rotate 8 circle anterior. In the first group here, the occiput reaches the pelvic floor and rotates only 1/8 circle. While in the second group, non-rotation happened because anterior and posterior fontanelle at the same level, which is a moderate degree of deflection. The third group, the sensibot reach the pelvic floor first and will rotate its circle anterior. And when the sensibot rotates its circle anteriorly like that, so the position will be direct occipitoposterior, because the occiput will be directed 1/8 circle posterior, because the sensibot directed 1/8 circle anterior. Okay? This occurs with major degree of deflection in which the sensibot is felt below the occiput during BV examination. We'll see the sensibot at lower level than the occiput, and this is the major degree of deflection in occipitoposterior. This will cause occipitoposterior, and this group of the patient, 50% of them can be delivered as a face to pubis by flexion spontaneously, and 50% will need interference by manual rotation, by helping by forceps delivery to help the delivery of the head in flexion. Okay, so direct occipitoposterior will be delivered either spontaneous or by using forceps. Okay, this group constitutes 10% of and include the abnormal mechanism. And the normal mechanism constitutes 90% with 3/8 circle rotation anteriorly and delivered as occipito anterior. So, what is the incidence of incomplete forward rotation and deep transverse arrest? It is 1%. What is the percentage of non-rotation oblique posterior arrest? Is 3%. What is the incidence in malrotation in which the sensibot rotates 8 circle anterior, causing direct occipitoposterior? Is 6%. This is the normal mechanism as we explained, and this is the abnormal mechanisms. The first group with mild degree deflection will be deep transverse arrest. The second group of abnormal mechanism in which the head will not rotate with moderate deflection of the head, persistent oblique posterior. And this is the third group in which the sensibot rotates its circle anterior and becomes direct occipitoposterior or face to pubis. And this is the mechanism of labor in direct occipitoposterior or face to pubis. 50% will be delivered spontaneous, and the head, of course, should be delivered in flexion. Not like occipito anterior, which is delivered in extension. In direct occipitoposterior or face to pubis, the head delivered in flexion, or with the use of forceps in the other 50% of cases with direct occipitoposterior. So, what about the first stage and the second stage of labor in occipitoposterior position? During the first stage, there is delayment of descent, engagement, and the delayment in cervical dilatation and the effacement. And the first stage is prolonged due to inefficient uterine contraction, while the second stage of labor, the occiput remains posteriorly until the head is well engaged and reach the pelvic floor. And as we mentioned before, we have two, either the normal mechanism or the abnormal mechanism of labor. What is the triad problem in occipitoposterior? Look to this picture, please. The first in the triad is the ovoid plane of engagement, as in android pelvis, which leads to inefficient uterine contraction and the premature rupture of membrane. The second is the head must rotate 3/8 circles, so it needs much more labor pain, leading to expulsion of the uterus and abnormal uterine action. To take this long journey of rotation of 3/8 circle. The third, in the triad, the occiput must descend distance of 10 centimeter, which is the length of the sacrum. In case of occipitoposterior, this is the length of the sacrum is 10 centimeter, while the length of the symphysis pubis is 5 centimeter. So of course the sacrum is longer, so the head should descend this longer distance, which is 10 centimeter. Also, the large occiput will distend the perineum when reaching the perineum and will cause perineal bulge and may cause perineal laceration. So these are the triad of occipitoposterior. What is the good and the bad omens in occipitoposterior? The good omens in occipitoposterior that favor long anterior rotation include good efficient uterine contraction, roomy pelvis, average size of the head, which is better to be well flexed, good pelvic floor tone with muscle tone is good, no premature rupture of membrane, when the anterior shoulder is not far away from the midline. What are the bad omens in occipitoposterior that cause failure of long anterior rotation? Weak uterine contraction, abnormality in the shape of the pelvis as projecting ischial spine, convergent side wall of the pelvis, funnel pelvis as an android pelvis, persistent deflection of the fetal head, relaxed pelvic floor as in multipara. Less important cause include full rectum and the bladder and the ileal rupture of membrane, presence of pelvic tumor or large head, or presence of placenta previa, or using epidural anesthesia. What is the management of occipitoposterior position? During pregnancy and during labor. Actually, during pregnancy, there is conservative management or expectant management. But you may encourage the patient to lie in bed in exaggerated left lateral position, hoping for correction to occipito anterior as in this picture. Another position, which is hand and the knee posture. And there is Cochrane review about this posture or position in late pregnancy or labor for fetal male position, and they concluded that adoption of this procedure for 10 minutes daily in late pregnancy has short-term potential to change the fetal position and reduce lumbar pain, but doesn't influence delivery outcomes. What about the management during labor? During first stage, if you found contracted pelvis, contracted inlet from the start, so arrest at the pelvic brim, do cesarean section. Don't wait anymore. So arrest at the pelvic inlet, do cesarean section. If the head descending through the pelvic brim, watchful waiting is the proper course to be taken, and be careful to use partogram to see the descent of the fetal head and cervical dilatation, and to follow the progress of labor, and if it goes very well or there is crossing to the alert line or action line, so needs interference. So partogram is very helpful in diagnosing protracted and arrested cervical dilatation and descent of the head. Try to prevent premature rupture of membrane and try to prevent exhaustion of the mother, combat inertia by evacuation of the bladder and the rectum and give intravenous fluid, minimize vaginal examination, observe fetal heart sound every 30 minutes. During second stage, constant supervision for both mother and the fetus is important. Of course, I wanted to avoid prolonged second stage, so never to exceed 2 hours. Try to be less than 2 hours. If there is inefficient uterine contraction, you can give Pitocin infusion to get 3 to 4 contraction per 10 minutes, each one for 1 minute duration. So if long anterior rotation occur, as in 90% of cases, the case will be delivered as an occipito-anterior with no problem. This occipito-posterior will be changed to be this is occipito-posterior position will be changed to be occipito-anterior, but both of this picture are occipito-posterior. This is a right occipito-posterior and this is a left occipito-posterior. Rotation will happen as in this picture, like that, for the left occipito-posterior. So the occiput will be anterior and delivered as occipito-anterior. On the other side here, this is right occipito-posterior, the occiput directed to the right and the posterior. So rotation 3/8 circle anterior and delivered as occipito-anterior. And this actually occurs in 90% of cases spontaneously. What about the abnormal mechanism, which constitute 10%? We said before we have 3 groups, either deep transverse arrest, which will need cesarean section immediately because the labor is obstructed and you are afraid from rupture uterus, uterine rupture. So deep transverse arrest will need cesarean section. Oblique occipito-posterior or persistent oblique occipito-posterior, I can use position management, manual rotation of the fetal position, and using U-shaped birth stool, as you see here. This is U-shaped chair. So position management, manual rotation of the head, and U-shaped birth stool may be helpful and also help in reducing pain and help in the descent and the rotation of the head, or using manual rotation and the forceps extraction, or use the rotation and extraction both by forceps, but this is injurious to the mother and the fetus, and in modern obstetrics it is of little use, or use of vacuum delivery, or going to cesarean section, which is safe if the labor is difficult. Craniotomy for dead fetus, you can use it, but in modern obstetrics it is also of rare use because of its hazards on the mother. Okay, so this is the lines of treatment in oblique occipito-posterior, and we said deep transverse arrest will be delivered by cesarean section. What about the direct occipito-posterior? 50% of cases will be delivered as a face-to-pubis spontaneous. The other 50% will need forceps delivery and with the aid of mediolateral episiotomy. Why mediolateral episiotomy? To avoid perineal tear and extension to the anal sphincter, because the Perineum is distended with large occiput in case of direct occipitoposterior. Also, the vulva is distended with larger diameter, which is 11.5 centimeter, which is the occipitofrontal diameter. What is the complication as regard the maternal and the fetal? Maternal may be obstructed labor with, as in deep transverse arrest or resistant occipitoposterior also, exhaustion from prolonged labor, perineal lacerations or tears that may extend to the sphincter or anterior rectal wall, causing fistula, atonic postpartum hemorrhage, anesthetic complications, and the operative delivery risks, venous thrombosis and pulmonary embolism, purpular sepsis. What about the fetal complication? Include intracranial hemorrhage, birth injuries, cord prolapse, asphyxia. This is the last slide. Thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine.